My name's Colin Macduff. I'm Head of Research and Scholarly Activity in the School of Nursing and Midwifery at Robert Gordon University here in Aberdeen. My background's in nursing, and in the last 20 years I've been doing nursing and healthcare research. This project called Visualising the Invisible came about through some of my clinical experience. I was always interested in what went on in healthcare staff's heads in regard to the topic of healthcare associated infections and the pathogens, the microorganisms that under certain conditions can cause the healthcare associated infections. And as a nurse, I often had a kind of internal kind of mind's eye audit of how contaminated my hands might be, for instance. So that was something that was part of my clinical practice. Many years later, getting involved in health service research, I was evaluating a national programme in Scotland called Cleanliness Champions, a programme that's for the education of prevention and control of healthcare associated infections, and it's aimed at all disciplines, across the healthcare environment. So cleaners, admin staff, nurses, doctors, and it's been very successful indeed. And as part of that, I became more and more interested in this relationship between education around people, pathogens and places. So there's these three main elements that interested me, the people, the pathogens and the places. And I wanted to take this a little bit further. And as it happened in about 2011, the AHRC, the Arts and Humanities Research Council, came up with an invitation for healthcare researchers to engage with arts and humanities researchers in order to address relevant issues. And this, I'd held on to this issue as something that I would be interested in taking further. By this time I was very experienced in healthcare research, and so I ended up kind of looking for partners to develop an idea around what we call visualising the invisible, exploring how healthcare staff perceive these pathogens that cause the healthcare associated infections and how the healthcare staff behave. And also later on we brought in the idea of how we visualise important data that's coming through from research. So there was a chance then to try and develop quite a multidisciplinary project, and the AHRC set up a sandpit event, as they call it, and I went along to that and ended up getting into a good conversation with a couple of design researchers who are particularly interested in visualising data, visualising material in a sort of dynamic way. And these were Dr. John McGee from University of Dundee, Professor Alistair MacDonald from Glasgow School of Art, and Dr. David Loudon from Glasgow School of Art. And the final part of the jigsaw was meeting with Dr. Stephanie Dancer from NHS Lanarkshire, who's a well-known microbiologist who's very interested in how these pathogens might be transmitted, and is interested in staff education and not narrow education. She's interested in education for particularly the role of cleaners. So the conjunction of these things was the context for this project. So we got to a stage with the design of the project that we were thinking about key questions to answer. So I'm just going to go over some of the main questions that we came up with, just to give you the context. So the first one was really that, given that pathogens are under normal circumstances invisible, how do healthcare workers in medical and surgical care settings actually envisage pathogens? And what does this mean in the context of their daily working practices? So it's just trying to think about the mind's eye in HAI, as we would say, and the meaning of pathogens and behaviour around that. So that was really the first thing we looked at. Related to that, we were interested in what current ways of representing pathogens and their consequences are most meaningful to the healthcare staff in terms of perceived influence on their awareness and their behaviour. So this was looking at things like existing posters, existing educational material, and we envisaged working with a sample of healthcare staff to try and address that. The third thing was taking the challenge of new data, and all the time there's interesting new data coming out, but often it's visualised in things like detailed graphs and bar charts and tables that are very kind of specific with dense text. And we thought there was scope for a more sort of dynamic visualisation of these, particularly incorporating meaningful context. So we were interested to work with staff to see if that would be, if we could elicit their perceptions around that. And finally, we wanted to produce a sort of suite of dynamic visualisations that were based on this sort of elicitation of data and on the perceptions, and try and evaluate them with the staff to see if these were meaningful to them. So that was the kind of nature and the scope of the project. And obviously that was quite a bit to be addressing. And I suppose the key question for us at that point as a multidisciplinary team was, how would we actually go about answering these questions? Were there methods that existed from our own experience in healthcare and design, or would we have to be creative and try and sort of improvise? So I think the questions, when we consider them, they bring in elements obviously from clinical nursing, is relevant to them. We had an artist involved in the team. We had several people from design, as I've said. We had 2 microbiologists, and we could have brought in sociology and psychology because they would have been relevant as well, but we had to set a limit somewhere. So, so very different disciplinary perspectives. And I think I've been involved in quite a range of different healthcare research, but I couldn't think of one particular approach that might encompass all of this. So there was quite a process of working together to see what we could come up with to address these questions. So for the first question, exploring the mind's eye in HAI, we worked with a sort of small group of volunteer healthcare staff from different occupations. So that included cleaners, included nurses, included a sort of architectural consultant, and also importantly included service representatives, so basically representatives of patients and families who were involved with the hospitals in auditing work as well. So we wanted to try and get quite a broad perspective, and we came up with a sort of ideas for a pilot event. So that was planned, and one of the interesting aspects of working with the designers was that we found we needed quite a lot of flexibility to exchange ideas, and we had worked out a plan for our first workshop to bring the healthcare staff together and go through these questions with them and different methods, mostly interactive sort of co-design methods. But we found on the way, one of the designers was coming from Dundee, and a couple were coming from Glasgow. And on the train up to Aberdeen, they met for about 60 minutes and had a bit of a conversation which sparked a change in the protocol for one of the workshops. So that was quite interesting as the PI on that. What I had to do was to listen to them, engage with what their ideas were, and quite quickly we worked out that would be a good way to proceed. So we ran that as a dry run with the first workshop as a pilot, and we found it worked quite well. So to say a little bit more about that, there's a poster behind me that refers to, it's a blow-up of a clinical situation, and what we wanted to do with the staff was to get them to talk about their role in that clinical context and to actually explain what they would typically be doing in a room like that, and to actually indicate their perceptions of points of risk for contamination and spread of pathogens. So that was to try and get an insight into their thinking and their behaviour. And of course we recorded that and tried to elicit questions. So I think that was quite a sort of designerly way of approaching that particular question. The second part of the workshop was involved in trying to elicit people's perceptions of attributes of pathogens. And again, this was a sort of creative approach, so we got people to work with quite a diverse set of materials, included things like plasticine and foam, there was pens, there was paint, there was paper, quite a diverse range of materials, and invited people to create a representation of a pathogen or pathogens. And we worked with them again, recording what their thinking was, but we were trying to elicit basically the sort of attributes that they would give to pathogens, so things like their colour, any sort of movement and characteristics, again to try and get an insight into the mind's eye. So again, this was an approach I wouldn't necessarily typically take just from a pure kind of health service approach, so I valued the input of the designers with that. The third stage was eliciting perceptions of existing representations. That was probably a bit more of a sort of traditional focus group type of activity. And then that was really the end of workshop 1, and in later stages the designers and visualisers went and created the related dynamic visualisations. Workshop 2, we evaluated that, and we moved through to the final part of the project where there was these visualisations created. And we've now gone on to, with further funding from the HRC, to try and test these visualisations in an educational format with the different groups of healthcare staff using tablet-based computers. So that's we see that as quite a satisfactory outcome. The input of the designers in the project was, I would say, multifaceted. In the second phase of the workshop 1, where we were trying to elicit people's perceptions of attributes and characteristics of pathogens, I'd say the designers were quite skilled in trying to do that. So we got from people as we worked together to sort of make representations. We got things like attributes of movement from pathogens. A lot of people were sort of reference like insects and kind of spiders and things came out from that. Also we tried to think about, tried to elicit where people had actually got these ideas about pathogens, and some people spoke about textbooks and things when they were studying science. Interestingly, we got information from some of the nurses about the associated smells, so all of the senses could be relevant in that sense. So the designers were useful in helping us elicit information, but they were also useful in taking that information and then trying to make visualizations from it in a dynamic way. So they kind of went back to the lab, as it were, or back to the art schools variously, and worked on the sort of on the computers to make sort of 3D visualizations based on some of these perceptions. And that was a sort of basis for then using them as prototypes to evaluate. So I would say the design input was kind of multifaceted, but it also did need the sort of anchoring from the perspective of health and health service. And I think that's where we worked together quite creatively and usefully. I think what is important is you have to have a kind of respect for other people's sort of traditions and different ways of thinking and seeing. And I think if you're open to that, it can be quite a rich experience. As we went on, we kind of built up more and more trust in each other's judgment. And also trust to be able to disagree was important, because sometimes at first you might be a little bit shy about kind of expressing opinions in the team. But as things went on, we would be more kind of frank about that, I suppose, and that's an important part of the research team working. So I would say that designers brought a lot of really useful perspectives, and one of the interesting things for me as a health service researcher is that we often have some some fairly fixed ways of approaching questions. Some of these are very effective indeed, things like randomised control trials for answering specific questions, of course. But the sort of questions we were trying to answer didn't necessarily have a sort of characteristic associated definitive research approach. And where that sort of flexibility was needed, involving design alongside health research was important, and I think worked quite well. It worked well in a practical sense, but it also worked quite well in terms of getting us into sort of thinking about underpinning theory. So I was exposed to some theoretical perspectives that I hadn't been aware of before. Things like the sort of design notions of co-design, quite similar in many ways to the sort of participatory action research approaches that characterise a lot of health service research, but with some differences. But also Edward Tufte's work on data visualisation and the sort of idea of does data actually enunciate its own structures. That really got me thinking about the sort of material we were working with and how would you try and represent data in a way that's meaningful to a healthcare audience. So there was quite a number of different perspectives on that within the team. So that was interesting, and the other framework we used quite a bit was Sullivan's dimensions of visualisation, which we actually wrote a subsequent paper around. So it took us into some interesting theoretical territory, and we're still kind of working through with that. I think one of the challenges of working with designers and the context of a kind of fully funded research project like this over a long time is that you do tend to think things through in a very considered way, which is good. But it's a challenge to recruit healthcare staff whose time is very limited, and you have to try and exploit every existing opportunity. So for instance, for the evaluation of the prototypes that we created, we got a slot in one of the big conferences and ran the dynamic visualizations in real time on screen. And we got quite a big audience of several hundred mixed healthcare staff to use voting buttons to give us their feedback on that. So I think you have to be, again, creative in terms of how you fit in with healthcare service staff's time. I think if this had been a project with a very sort of limited time frame on it, some of the visualizations might have been much less considered, and I could imagine some commercial companies may just produce sort of the best they could in a quick time to use for the educational purposes. So I think there's always going to be tensions and challenges in terms of the sort of time frame and the parameters. I think just reflecting on the Vis-invis project, we feel as if it's been really quite successful in terms of bringing together the team, multidisciplinary team, and creating some useful visualizations. With the Vis-invis website, we've had some good feedback on that. Indeed, just last week, got feedback from a nurse educator in Africa who's using some of the materials with his students. So that was quite gratifying. And we've been successful in getting some follow-on funding from the HRC to develop what we're calling the VisionOn project, which is an applied knowledge exchange project where the visualizations are going to be developed further, especially based on kind of real-time data from healthcare associated infections. Dr. Dancer again is supplying some of the data for that, and we're going to use that for educational purposes on the tablet-based computers, and we're going to work with a small number of healthcare staff to see if that's useful in helping them to understand and in terms of influence on their behaviour. So that's been a really helpful outcome. We've had involvement in the British Science Festival on the back of this as well, and had, as I say, quite a lot of interest from other groups. So We hope to develop further projects and looking at more detail about the mind's eye in healthcare-associated infection, and we do hope to expand activity. It's been very useful to have a sort of more flexible and creative approaches to draw on, and I think going forward to other projects, it's certainly something I would readily consider in terms of involving a wider team. And certainly with this group of researchers established good relationships. We hope that the work that we've done will not only influence healthcare staff, but in doing so will in turn feed through into their work with patients and families in the wards. So this is, we feel, an important area to develop further. I think finally one of the lessons that we would learn from working together as a team with designers and health service researchers is that of piloting any sort of new or innovative approach that you might want to use. I think that's something that I'm used to from health service research, but particularly when you've kind of expanded the repertoire of approaches that you're using and where something's a bit less established as a procedure, we found it really good to sort of test that and then reflect on it as a team on the value, eliciting from the participants themselves what they thought of it, and in that way to try and sort of further develop our ideas based on feedback. So that would be a key lesson.